The only exception to this is airway lesions, where if you've got a child, a newborn, born with a massive, neck mass such as a cystic hygroma, those children may need to have emergency surgery. The good news about those things is nowadays, with the advent of almost universal sonograms, most of these lesions are diagnosed antenatally, so we are prepared for it. In the situation where one thinks that the newborn is going to be faced with a massive airway issue because of some anatomic abnormality, such as a cystic hygroma or other mass in the neck, what we do is we prepare beforehand, and we often will do what's called an exit procedure, which is an ex utero intrapartum operation, where the baby is delivered in an operating room. The section is performed. The child is left attached to his umbilical cord, and then you can do some sort of operative maneuver while the child is taken out of the uterus, still attached to his umbilical cord, so that you can go ahead and secure the airway safely while the child is still being oxygenated through the umbilical cord. Okay. So most of these children can be resuscitated, and then you can investigate and see what's going on. So let's talk about a case. A newborn weighing 2.9 kilograms, full-term baby, is noted to be in moderate respiratory distress with tachypnea, and you notice that he's a little bit blue. A pulse oximeter is placed on the right hand, which is the better hand to do it, because that's called pre-ductal O2 saturation, in case there's some sort of anatomic problem with the aorta or some sort of shunt across the great vessels. The best way to check the oximeter is on the right hand. You see that the oximeter is 82%, which is quite low. Most babies will have an oximeter reading well in the 90s. There was an antenatal sonogram that you remembered, so the obstetrician told you about, a suggestion of a mass in the left chest, but this was possibly due to an artifact. It was not repeated, and you were not sure what a diagnosis was. The pregnancy is otherwise uncomplicated. You are called to the delivery room to evaluate this baby, to see what's going on and how you can best manage it. So what are the next steps? Okay, so as you start working this baby up, you start thinking, what are the possibilities? Okay, what are the major issues that be facing this child that I need to think about? Congenital diaphragmatic hernia, that's one. As surgeons, we love to operate on those things because they're intriguing and the physiology is stimulating. Second one is what used to be called CCAMs, or congenital cystic adenoid malformations. Nowadays, the word CCAMs is no longer used. We now call it CPAMs, which is congenital pulmonary airway malformation. The third one that the boards, for some reason, love to talk about are pulmonary sequestrations. They come into two categories. There are the intralobar sequestrations. These are pieces of abnormal lung tissue sequestered within a lobe. It doesn't have its own visceral pleura. And finally, you have extralobar sequestrations. Again, abnormal lung tissue, which is usually in the lower lobes, more commonly in the left chest than the right chest. And unlike the intralobar sequestrations, extralobar sequestrations do have their own visceral pleura. They look almost like little pieces of abnormal lung or supernumerary little lobes. Congenital lobar emphysema is the other issue we'll talk about. And finally, bronchogenic cysts. These are cysts usually attached either to the bronchus and also in some rare cases into the esophagus, which is closely adherent to the trachea. Okay, so importance. ABCs, like everybody else, babies need to be, you need to follow ABCs. Airway, breathing, circulation. Do not hesitate to intubate the patient. As a rule, bagging patients, excessive bagging of these patients is not a good idea. All right, so if you have to, the baby's in real distress, sats are dropping, heart rate is starting to drop down, intubate the baby, do not bag. Do a quick physical examination. What you're looking for is you're looking to listen to lungs, you're looking to see the size of the abdomen, and you listen to hear breath sounds or bowel sounds in the chest. If you've got bowel sounds in the left chest, you got a scaphoid abdomen that almost clinches your diagnosis. Okay, labs, lines, obviously. Babies, thank God, have umbilical vessels that are easily approachable by either the neonatologist or by yourself. Okay, you can use both the umbilical arteries and the umbilical veins. These will give you access to the central circulation and give you a good handle on measuring oxygen saturations. Pre- and post-ductal saturation probes, okay, right hand, left hand, or right hand and the foot, okay. In all these cases, okay, as surgeons, okay, we love these tubes. Nasogastric tubes are important and need to be unsuctioned. And finally, get a chest x-ray. Okay, so you get a chest x-ray. All right, what's going on here? All right, so if we look at the chest x-ray, we can see the baby's already intubated. The tube is shifted a little bit to the right. Okay, you can see that the heart shadow is all the way over to the right. You can see that his nasogastric tube is someplace in the lower esophagus, probably not completely in the stomach. And more strikingly is the fact that the left chest is totally abnormal. Okay, and before you start sticking tubes and needles into the left chest, remember, the most likely diagnosis in these situations with a scaphoid abdomen and breath sounds in the left chest is a baby with a congenital diaphragmatic hernia. The last thing you want to do is stick a needle into this baby's chest. Okay, so diaphragmatic hernias. Okay, you've got this situation. You've got a compressed left lung, very compressed. You've got a shifted mediastinum. You've got a right lung, which is probably small and compressed as well. You've got a bunch of bowel up in the chest, and you've got a stomach, which may also be in the chest. Important things to remember about congenital diaphragmatic hernias is that these things are lesions that have both anatomic and physiologic sequelae for the baby. The anatomic ones are obvious. The physiologic ones are a little more subtle, but are important as well. Okay. Treatment of diaphragmatic hernia, and this is critical, guys. This has changed over the last 20 years. These are not surgical emergencies. These babies need to be treated very gently with kid gloves. Okay. The operation, the surgical operation, is delayed until the baby is stable on low ventilatory settings. Okay. We can either use a conventional ventilator. Depending on the hospital that you're in, you may want to use a jet ventilator, an oscillator. Okay. Okay. What we've learned over the last 15, 20 years, and this is thanks to the group at Columbia, is that babies can have little low O2 sats and elevated bicarbs and still not be in distress, not be damaged. So we use gentle ventilation. You can have what's called permissive hypercapnia, where the PCO2 will rise. Okay, as long as the baby is, has a stable heart rate and has reasonably stable blood gases. If conventional ventilators do not work, then we go to these advanced ventilators. If advanced ventilators don't work, okay, a lot of centers will use nitric oxide as a pulmonary vasodilator. It's still in vogue in some centers. I can tell you in the large groups, in the large centers such as Boston, Philadelphia, if a baby fails conventional or advanced ventilators, the next step would be ECMO, extracorporeal membrane oxygenation, which is required about 15, maybe 20% of the time when babies with congenital diaphragmatic hernias. Okay. Most of us will use what's called veno-arterial ECMO, cut downs made in the right internal jugular vein and the right carotid, and cannulas are placed, and baby is placed on ECMO, okay, while his lungs are allowed to recuperate. Once the baby is stabilized, okay, then baby is either operated on while still in ECMO, depending on which group you're in. Others will wait until baby's off ECMO, place them on conventional ventilators, and then we'll do a repair. Okay. Patches are sometimes necessary. Most cases of patches not necessary. Nowadays, the survival of babies with congenital diaphragmatic hernia is about 50%. They're still very, very sick. So, pearls to remember about congenital diaphragmatic hernia. These are, I think, questions that the board's left to ask. These are always, well, not always, these are usually on the left side, and the defect is posterolateral. Okay, again, posterolateral on the left side. Right-sided diaphragmatic hernias are less common. They're a little less stressful because the liver usually, kind of tamponades the defect, okay, but not as common as the left side. Morgagni hernias are also congenital diaphragmatic hernias. These are retrosternal. Okay, they present late, and it's highly unusual to diagnose a Morgagni hernia in infancy. The defect with diaphragmatic hernias is not just that. Sorry?
This ball glows in the dark.
Dr. Weinberg, you have to just there you go.
Okay, you were good? Sorry, I didn't do it. It did it on its own. Can you hear me now?
Yes, we can hear you, sir. Go right ahead.
Okay. So the lung hyperplasia of a diaphragmatic hernia affects both sides. Both the right and lung are damaged. So that's important to remember. The issue with the diaphragmatic hernia is not so much the size of the defect, that in fact you got a bunch of bile up in the chest. The real problem is that you have what's called persistent fetal circulation with a resultant pulmonary hypertension. And that is the major issue, which is why we nowadays will wait until this hypertension decreases, as it does normally during the first few days of life. Okay, pulmonary vasodilators may help a little bit, okay, but the key is not to operate until the baby is stabilized. Remember, some of these babies have these honeymoon periods, everything looks wonderful, and also until crash. So just be careful. All right. And I am frozen here. Okay, lobar emphysema is a different sort of pathology. Here, for some reason, we usually upper lobe or lower or middle lobe, okay, will hyperinflate for reasons we really don't know. We think there may be a defect in the cartilage structure of the lobe. Okay, these babies present with a increasingly large lobe, which is hyperlucent, will compress normal lung tissue. These babies will usually need an operation, and that lobe needs to be removed. Okay, there's air trapping, and you got to be careful that you don't want damaging that babies don't go into distress. Okay, these are important lesions. Okay, again, these are something that the board talks about now. The CTAMs, or the adenoid malformations. Usually, these are lung tissue which is abnormal. Present usually antenatally, picked up in an antenatal sonogram. If large, they can cause fetal hydrops and actually fetal death. When these babies present with these large CTAMs, they usually have respiratory distress. Okay, the small ones usually are picked up on a routine chest X-ray. Most of us now feel that these cystic adenoid malformations, okay, are precursors in some cases to what are called pleuropulmonary blastomas. These are malignancies, rare but still present cancers of the lung. And most of us feel now that these CTAMs should be removed. We usually wait until the babies are 4 or 5 months of age. Most of these lesions can be removed thoracoscopically. Okay, let's move on. Okay, any questions on pulmonary lesions? Can you guys hear me? We're good? Hello? Anybody home?
We're good, Dr. Weinberg.
Okay.
Yeah, we can hear you, sir.
All right, good. So next case. Baby is 2.8 kilograms. He was born through normal vaginal delivery with normal Apgars. Everything looks great. The nurse in the newborn nursery attempts to feed the baby, and she winds up noticing that the baby has copious secretions. baby takes a couple ounces and will start coughing his brains out, turns a little bit blue. She resuscitates him. She clears the meconium, clears the foramen from his mouth. Baby otherwise looks good with a nice soft belly. Baby's already past meconium. What's the problem here? What do we worry about? Okay, we worry about some sort of lesion in the upper airway or the esophagus, which is preventing the baby from feeding properly. I see somebody mention TE fistulas. Okay, so let's talk about it. Possible tracheoesophageal fistula with or without esophageal atresia. So that's what you worry about as a surgeon. Okay, what's the next step? Classic. The board will ask you, what is the next step? Very good. Nasogastric tube. You attempt to place a nasogastric tube. You look on the right chest X-ray there, and you can see that the nasogastric tube is up in the upper chest around the third or fourth vertebral body. Doesn't go anywhere. Okay. What's different between the X-ray on the left and the right? Okay, the X-ray on the right. Okay, no gas in the below the diaphragm. Totally gaseous abdomen. The only thing you see is the umbilical cord clamp. The X-ray on the left shows, as the arrow points out, air in the stomach. So, right side is a esophageal atresia without a TE fistula. The left one is a type C TE fistula with esophageal atresia. Okay, the difference is that, all right, so before we go crazy and start planning our operation, let's remember that TE fistulas are usually not isolated anomalies in these children. Okay, they're usually part of a syndrome. So Vactorel is the one the boards love to talk about. Vertebral anomalies, anorectal anomalies, cardiac anomalies, okay, tracheoesophageal obviously, renal anomalies, and often radial limb anomalies where absent radiuses or very abnormal radiuses. Okay, all these anomalies are important. They need to be worked up. The one that is critical is C, okay, the cardiac anomaly. And the reason that's important is because if the baby's got a significant cardiac lesion, okay, that may certainly change to what you're going to do, your management, and the baby's prognosis. Okay, so whenever I see these babies, I look for these anomalies. And before we do anything else, I always make sure our cardiologists are involved and listen to the baby's heart, see if they need to do an echo or other workup to decide what to do as far as the, and the PowerPoint disappeared, somebody says. We still there?
Yeah, your PowerPoint stopped, sir.
So, I'm sorry?
Your PowerPoint stopped for some reason.
And now it's okay?
No, I don't see it.
Nothing there?
Nope. Try to share again.
How about now?
Yep, there you go.
All right. All right, so assuming that the cardiologist says everything is good to go, the baby's a nice size, okay, the next step, once you've resuscitated the baby and worked them up and gotten blood ready, is to do a right thoracotomy. Try to identify the upper esophagus and lower esophagus and do what's called an esophagostomy. Okay, it's sometimes a challenging dissection. The upper pouch is usually quite large and nice and thick and easily hold your sutures. The distal end is usually very, very small, and putting sutures are a little bit challenging, but can be done. Okay, it takes a little bit of patience, a little bit of time. Okay, but it can be done. If the two ends look like they're very, very far apart, the long gap esophageal atresia, then you may not be able to put the two ends together. At the very, very least, what you want to do is you want to tie off the fistula so you don't have a connection between the trachea and the esophagus. Leave the two ends of the esophagus in place. Okay, put some proline sutures so you can identify them. And then down the road, as the baby grows, the two ends usually get a little bit closer. The gap narrows, and then you can do a primary esophagostomy. I place a chest tube. If I do my operation retropleural, the chest tube basically is a retropleural chest tube. Do you put in a anastomotic feeding tube. Some babies, some do, some don't. Okay, it's a bit controversial. Before you start feeding the baby, traction sutures is an option. There's a procedure done by some surgeons where they actually place sutures on both ends, bring them out through the chest, one above, one high, one below, and actually put pressure on these traction sutures, keep them there for several weeks, and every day come by, put a little more pressure on the traction sutures, and then you can do a primary anastomosis. It's a bit of a challenge, but it can be done. What I found with experience is that very often, just by coming by every day and doing a little balloon dilatation of these upper pouch, that the two ends will come together on their own. It sometimes takes a few months, but it can be done. In the meantime, you do a gastroscopy on the baby, so you can feed the baby through his GI tract and wait until the esophagus matures. In rare situations where you've got a very, very long gap, this is very common with babies with pure esophageal atresia. What you can do is you can do some sort of interposition down the road. Okay, colonic interpositions used to be very, very common. I think most of us nowadays do some sort of gastric pull-up, and it can be done when the baby is about a year of age. Okay, this is a typical question for the boards. Okay, the most common kinds of esophageal anomalies we see. The most common kind by far is the type C, which is the one in the middle, the upper blind pouch, and the fistula that goes from the lower esophagus to the trachea into the stomach. Okay, the next most common kind is the pure atresia. Okay, again, cardiac anomalies quite common. Other genetic anomalies, trisomy 21 is the one I've seen the most. GI anomalies, something else to think about, okay, but not as common. The one that everybody talks about, okay, which is probably one of the least common, is one all the way on the right, the type E, the fistula, the H-type fistula between the esophagus and the trachea without an atresia. Okay, these are usually picked up, and if children who are a bit older, 1 year of age, 2 years of age, they don't present with dysphagia or problems swallowing. They present with recurrent recurrent pneumonias, often right-sided, right upper lobe, okay, because of the fistula, and these are usually operated on again at year 1 or year 2, and are often done through a right cervical incision and not a thoracotomy. Questions? Complications, leaks, recurrent fissulas, esophageal strictures, quite common because you're putting two structures together on a fair amount of tension. These babies almost all have reflux and need to be treated through an anti-reflux management. We used to do very commonly Nissen fundoplications. We now know with time the reflux will get better. Tracheomalacia is because the trachea has been squished with the big esophagus during uterine development, usually resolves on its own. Okay, questions? We'll go below the diaphragm. Okay, this is really, really important. Okay, I don't care. I know you guys are interested in the boards and ABSITE, and it's important to do well. But if anybody here involved is going to be taking care of children, babies, I think this slide is probably the most important slide in this sorry lecture. Okay, bilious vomiting is relatively common in adults. Certainly, I think anybody who's taking care of adults in the emergency room, especially if you've got patients with gallstones, you'll see bilious vomiting. Okay, children rarely will vomit bile. Okay, especially young infants. Okay, especially newborns. If you've got a newborn who presents with bilious vomiting, green vomiting, that's a surgical emergency until proven otherwise. And the reason it's a surgical emergency is because bilious vomiting, to me, means he's got intestinal obstruction. And what scares the hell out of me is the fact he's going to have intestinal obstruction because he's going to have a malrotation and he's going to have a midgut volvulus. And if you don't operate within a few hours, he's going to wind up losing his entire midgut from just beyond the ligament trites to the mid-transverse colon. So it's a surgical emergency. So our job as surgeons or surgical residents or what have you is to identify these children and make sure that they get taken care of properly. Okay, so baby has bilious vomiting. You examine the baby. Baby seems okay. Maybe his belly is a little bit full, but he's not terribly sick. He looks fine. He's kicking. He's screaming. He doesn't have evidence of peritonitis on your examination. Okay, you get an X-ray. Okay, what's important to remember about X-rays is that you cannot differentiate small bowel from large bowel with any degree of certainty in a newborn infant. You don't have valvuli conventis you can see in a KUB. You don't have haustras. You cannot differentiate with 100%. All you can say is these loops look normal or they look a bit abnormal, and I'm not sure whether it's proximal or distal. I think it may be proximal because there are a few loops. Okay? If you look at the X-ray on the right, you've only got 4 or 5 loops of bowel, which look quite abnormal. If you look at the X-ray on the left, okay, it looks a little more like distal obstruction. You've got many more loops. That's all you can say. So, proximal obstruction, the things you think about are malrotation, some sort of stenosis, atresia, okay, jejunal atresia, ileal atresia, okay, these are common. But the most important thing you want to rule out is malrotation. Distal obstruction, you think of other conditions such as ileal atresia, meconium ileus, meconium plug. We'll get into it a little bit, and perfid anus. Okay, but again, malrotation. So the bottom line is you cannot tell on a KUB whether the baby's got malrotation or not. Therefore, you've got to perform a test. Now, this is what I tell my residents all the time. I don't care if it's the 4th of July, Super Bowl Sunday, Yom Kippur, Christmas, all wrapped into one. This is a surgical emergency, and you got to wake up your radiologist and make sure you get an X-ray. And this is what you get. You get an upper GI, and the upper GI is done either in the radiology suite, or if you've got the ability, you can do it even in our in your own NICU, and you look for the position of the duodenum and to see where the jejunum is. You look for the ligament trites. Ligament trites should be at the level of the gastric antrum, and you look to see if the ligament, if the stuff goes through the duodenum into the jejunum. If you look at this X-ray, this is a very, very abnormal X-ray. You can see that there is no really good ligament trites, and you can see that once the contrast leaves the proximal duodenum, it goes through this corkscrew into what looks like the proximal jejunum. So you got this X-ray, and your radiologist says, "Hey, Dr. Weinberg, don't sweat. Okay, this is a baby who's got malrotation, but he, stuff goes through. He's not obstructed. Okay, you can wait till the morning or the next day to take care of him. He doesn't have what looks like midgut valgus." The answer is absolutely not. This is a baby who needs an operation done right then in the middle of the night. Okay, let's talk about, before we get back to malrotation. This is, let's say you get this kind of X-ray. Okay, this X-ray shows what's called a double bubble. It's associated with Down syndrome. Babies have congenital heart disease. They may also vomit. Okay, depending on where the atresia is, the babies can vomit either bilious material or non-bilious material. If these atresias always occur around the ampulla, around the second portion of the duodenum. If the atresia is distal to the ampulla, the baby will vomit green. If the atresia is proximal to the ampulla, they will vomit non-bilious material. You get a double bubble. You think that you're okay, and these babies can get an operation, and these operations don't have to be necessarily in the middle of the night. These are stable babies. You can work them up for cardiac anomalies. If you think this child's got Down syndrome, you can certainly take your time, have the cardiologist evaluate him, discuss with the parents what the options are. Okay, babies need an elective duodenoscopy. But the important key here is the last sentence on the slide. It's not an emergent operation, but you got to make sure you're not dealing with a malrotation. And sometimes it's a little tricky. If the baby has had this diagnosis antenatally, baby's got Down syndrome, I think you can be pretty confident this is duodenal atresia, and you can take your time about operating them. If you are not sure, if you don't think this is, or think this may not be duodenal atresia, or there's no antenatal suggestion this baby's got an atresia, then you're really better off not taking a chance and operating emergency. This is a more distal atresia, or a more distal issue. This is the baby who's got intestinal obstruction, who may or may not have some vomiting, maybe bilious vomiting. Okay? When you get an X-ray, you can see that he's got lots and lots of loops. This is a distal obstruction, and this is a baby who's got a microcolon, an unused colon, due to some sort of intrauterine vascular accident. Okay? These babies can be operated on relatively electively. These don't have the same sort of urgency as a baby with midgut volvulus. Okay, so scenario. 4-day-old baby has a 12-hour history of bilious vomiting. He's a little bit lethargic, decreased urine output. He had a little blood in his bowel movement. Okay, you see him in the emergency room. He's got a softly non-distended belly. Okay, how do you work this up? Answer? What's the answer, guys? Upper GI. And this is what you see at the upper GI. This is what you do when you operate on him. You can see that he's got terrible, terrible looking loops of bowel. Some of them in the foregut are, in the forefront are kind of dusky. The other ones are all distended. Okay. You detorse. This is a malrotation from a midgut volvulus, or a midgut volvulus from a malrotation. The bowel is detorted, untwisted, okay, counterclockwise. You turn back the hands of time, and you do a LADS procedure. A LADS procedure involves eviscerating the entire bowel from the duodenum all the way to the cecum. You splay out the root of the mesentery. You divide LADS bands. These are pre-peritoneal bands that usually cross over the proximal bowel. You try to make the root of the mesentery as broad-based as possible, which winds up, when you wind up with a situation where your duodenum then goes straight down to the right of the vertebral column. All the jejunum is in the mid-abdomen. The cecum winds up in the left upper quadrant. You take out the appendix because the cecum is going to be in a quite abnormal position. You do an appendectomy, and you do what's called a LADS procedure. Okay, it doesn't require any suturing. We don't try to keep the bowel in place. It never works. Okay, you just want to split this out, and with adhesions formation, okay, it's unusual to have a recurrent volvulus. Question: what do you do if bowel looks damaged or looks beyond salvage? Questions? Any answers? What do you do? So we're trying to be as conservative as possible. Babies have pretty resilient bowel. You try to leave stuff which is marginal alone. I will usually put a silo on the baby's abdomen, and so I can monitor the bowel every few hours in the NICU. If it's obviously totally dead, I remove the dead bowel. I usually just staple across it and come back in 12 to 24 hours, re-examine, okay, taking back the operating room, open them up, take off the silo, examine, see what's going on. Okay, any more dead bowel I resect. Okay, and then I can do a primary anastomosis, putting the ends of the bowel back together again. These babies will often be sick for quite a bit of time. They need to have some sort of central line for access, whether it's a Brovac catheter or some other, long-term, a jugular line, so you can give them some TPN while they recuperate. Okay, questions? Malrotation, midgut volvulus, really, really important. Another baby. This baby is 3 days old. He's been vomiting on bilious material all day. He's got a very distended belly. Above doesn't seem to be in any pain. And the nurse tells you that in spite of the fact that he's breastfed a few times, he has not passed any meconium since birth. Okay. What do you do before you get involved with all kinds of fancy, sophisticated studies? Any questions? Any Any comments? Okay, so somebody raised a question, could this be necrotizing enterocolitis? Okay, it could be. What would be important to know about, whether this could be neck, whether that's part of the picture? Is he full term? Exactly. Is he premature? Okay. Full term babies rarely, highly unusual to have necrotizing enterocolitis. These are usually younger babies, usually premature babies, usually around 28 weeks, 30 weeks of gestation, and to have it on day 3 is a little bit uncommon. Okay, most babies who develop neck usually develop neck in the first week, after the first week in the NICU. And the reason for it is we're not sure, but possibly has to do with the fact that they get infected with some nasty bugs from the local NICU environment. Okay, so it'd be unusual for a 3-day-old baby to have this kind of neck, especially if he's not full term, if he's not a preemie. All right, so you examine the baby, and this is really important. I had one child with something similar that I remember taking care of when I was a fellow. Okay, and I went to examine the baby, and I asked him, "Is the baby otherwise okay?" She says yes, and I flipped through his charts, and looked like a normal baby. Didn't pass any stool, had normal rectal temps for 3 days, and when we went to examine the baby, and this was a male child, okay, he had an imperfect anus. Okay, and what was bizarre to me, and I still can't fully understand, is how she was able to chart normal rectal temperatures for 3 days. But so be it. Okay, you do a rectal exam before you do any sort of X-rays. Do a rectal exam, and you do the rectal exam, and you are met with explosive, foul-smelling green stools, which flies across the room and hits another isolate. Okay, what do we got here, guys? No free air. We didn't even get in a KUB. So good question. This is before we do any sort of KUB. He's distended, he hasn't passed stool, and you do your rectal before you do your X-ray, and you get explosive green stool. Okay, so what's going on here? It's not an imperfect anus. Okay, it's not some sort of atresia because the stuff is green. Okay, it's not neck. He's a full-term baby. Okay, could this be cystic fibrosis? It could be. It could be. We'll talk about that in a bit. Okay, more likely than not, this is going to be Hirschsprung's disease, right? Aganglionosis of the colon. Okay, Hirschsprung's disease always starts at the bottom of the colon, okay, and extends proximately, usually rectosigmoid, but it can involve the entire colon, and rare cases, the entire GI tract can be aganglionic. Okay, so that's your differential diagnosis. Okay. Why is this not a malrotation? Because babies usually with malrotation will have had normal bowel movement, and they usually don't have this kind of distension, and they usually don't have explosive, foul, green-smelling stools. That suggests a colonic lesion. What is the workup? I'm frozen again here. Why this died? Right. Hello.
We can hear you, Dr. Weinberg.
Okay. So the workup, I'm good. I'm having all kinds of computer issues today. We should go to Apple. Okay. So you're worried about Hirschsprung's disease. Okay. So the next step is to get a KUB. And somebody made an interesting point. Okay, you want to make sure there's no free air. I mean, if he's a sick baby, he's distended, you want to make sure that something didn't perforate. Either you, when you did the rectal, or the nurse try to stimulate him with a thermometer. So make sure you get a KUB looking for free air. There's no free air. Okay, the next step is, okay, what is the major issue with Hirschsprung's disease? They get very sick. Not because they don't pass stool as much, is the fact that they don't pass gas. And the bowel gets tremendously distended with air, and that puts pressure on the mucosa of the colon, and they can get enterocolitis from colonic ischemia from the pressure of not passing stool. The important thing to remember is that enterocolitis, even nowadays, even in the year 2021, still has a significantly high mortality. So if you got a newborn that you suspect has Hirschsprung's disease, you really got to be aggressive as far as your workup and treatment. Okay, rectal biopsy is the treatment of choice. What often happens, even though suction biopsy is definitive, is that most of us will get a contrast enema before we do the suction biopsy. And I think I have a picture down the road. Okay, suction biopsy is done at the bedside. It takes literally 10 minutes to do. Okay, at the bedside, no anesthesia is needed. Okay, you're looking for absence of ganglion cells in the myenteric plexus, as well as hypertrophied nerve fibers. Let's remember, this is a pearl. 95% of babies, normal babies, will pass meconium first 24 hours of age. 98% will pass it in the first 48 hours. So if you got a baby who's now 2 days old, has not passed stool, you get suspicious. Down syndrome has a 10% association with Hirschsprung's disease. Okay, we'll talk about the different pull-throughs and operations down the road. Okay, but what's important is Hirschsprung's enterocolitis can be life-threatening, and what's important is that if babies will develop enterocolitis before you operate, they can still develop enterocolitis post-op. So I suspect Hirschsprung's disease. I will place an NG tube. I will start the baby on broad-spectrum antibiotics. I will then start warm saline irrigations. Okay, either I'll do it myself, I'll have my fellow do it. Okay, if you've got nurses that are really trained in a good children's hospital, you can have the nurses do it. But warm saline enemas, you really want to decompress this colon. Okay, this is what a contrast enema looks like. Okay, here's another pearl. If you do a contrast enema in a newborn, okay, the rectum has a larger diameter than the sigmoid. Okay, that's a pearl. If you look at this contrast enema, this is a view. You can see what looks like a normal-looking, anal verge. Then the rectum looks like it's spastic with some thumbprinting, and then you can see at the box with the arrows that there's a transition zone into the sigmoid. The sigmoid gets large; it's starting to become a megacolon, and you got a spastic rectum. So that's key to making the diagnosis. The problem with the contrast enema, and the reason I don't rely on it, is that sometimes in newborn you don't have this sort of classic finding. Suction biopsy is much better. Okay. In the meantime, you give this baby fluids, NPO, nasogastric suction, rectal irrigations. Okay, flagyl is a very good drug for enterocolitis. Question is, what do you do now? Okay, board question. What would you do to this baby? What are the options? Okay, you've decompressed him. He's now 5 days old. The pathologist calls you up and says, baby's got Hirschsprung's disease. I see hypertrophic nerve fibers. I don't see ganglion cells, okay, in spite of my spending an hour looking at the slides. What's the next step? Anybody? Okay, so Dr. Tritt would do a pull-through. Okay, Dr. Pruitt would do irrigation. So you can do irrigations until the cows come home, but it's not definitive. So here's the bottom line, guys. In the year 2021, if the baby is stable, is a full-term baby, and you've got the right environment, you can do a primary pull-through. Nowadays, most of us will do a laparoscopically assisted primary pull-through. It's not a swab anymore because it's a full pull-through. You can do it laparoscopically, and it's it's a nice operation. It's a bit challenging, but once you get the hang of it, it's a well-done operation. Okay, and that solves the entire problem right there in the newborn period. If you're not comfortable doing in a laparoscopic endorectal procedure or pull through, okay, then you can do a transanal rectal pull through. Again, the baby's taking the opium in the newborn period. You basically start your operation transanally, and you can actually dissect out the entire rectum transanally and then pull through a normally ganglionated colon, sigmoid, through your anus, and then do a primary pull-through. And that solves the entire problem once and for all. The third option, in babies who are sick, Okay, it's a missed Hirschsprung disease. He went home because nobody realized that he wasn't stooling well. He's now 3 weeks old, and he's got a big distended belly, and he's sick. These babies are not candidates for a primary pull-through. These babies need colostomies. You do what's called a leveling colostomy. You do the colostomy at the level where the ganglionosis begins or ends. Okay, you then leave the baby alone, and then bring it back in 6 months, and then do your pull-through. Okay, so those are your options. Key to remember about Hirschsprung's disease is that it could be very sick, it could make newborns very sick. You need to make the diagnosis early on. If the baby is stable, you can do a primary pull-through. If the baby is not sick, just play on the safe side and just do your colostomy, decompress the baby, and let him live to fight another day. Yes, absolutely. When you do your pull-through, please, guys, this is really important. You need a good pathologist. You got to go there and you got to speak to the pathologist yourself. It's good if you learn how to look for ganglion cells yourself. You make sure when you do your pull-through that your pull-through segment has normal ganglion cells. Sometimes you are what's called a transitional zone, where you've got a couple ganglion cells. They don't look perfect. Then take a little bit more. It's always a little better to take a wee bit more than taking a chance on doing your pull-through in a transitional zone. Okay. Then it's key. Never get out of the hospital, never leave the operating room until you make sure that you've got ganglion cells. Okay. What's going on here, guys? So you do a picture, an X-ray of a baby, another baby who's distended, and you see unevenly dilated loops of bowel. There may be some air fluid levels. It's not a great film. And importantly, you see bubbles of gas, especially in the right side. Okay, you say, gee, what's going on here? You know it's not malrotation. It doesn't look like it. Okay, say, well, maybe it's Hirschsprung's disease. Who said that? Very good. Oh, you guys know this all. All right, so I don't even have to lecture. So you do a contrast enema, and you see an unused colon, but it's not an atresia because you can see a whole bunch of stuff in the right side in the ileum. Okay, this is called meconium ileus. Okay, they love to ask this on the boards. Meconium ileus is almost always associated with cystic fibrosis. It is sometimes the first manifestation of the disease. Okay, what's important to remember is that you can break up meconium ileus into two categories: simple and complicated. Simple meconium ileus is like the picture I just showed you on the X-ray. Okay, baby's distended, it's not passing stool, it's got a small colon. You can almost feel the loops of bowel on the right side. Okay, these babies have an obstructed ileum with this inspissated meconium. You can try to see if you can irrigate out the meconium by using hyperosmolar enemas. Okay, well, I use gastrografin. Gastrografin has an osmolality of 1900. You dilute it a little bit. You bring the baby down to radiology, and very, very carefully, the radiologist has to flush this gastrografin through the small colon into the ileum to see if they can break up the inspissated meconium. The important thing to remember is that the colon is very small. If they try to push too hard, they're going to perforate. The second thing is sometimes it takes multiple attempts at using the gastrografin to still really flush out the meconium. Okay, if you got a good, competent radiologist and you're careful and the baby's in good shape, you can usually successfully evacuate the meconium. If the enema is not successful, if in spite of 3 or 4 attempts you cannot get the meconium to break up, then you have to go ahead and operate. If you've got complicated meconium, the baby's got a shiny red belly, he's tender, he's not good, you don't waste your time trying to do a contrast enema. You take the baby straight to the operating room, and at surgery, you do what needs to be done. That usually means you do some sort of enterotomy, usually in the ileum. I will use, again, mucomist. I've used dilute peroxide, break up the meconium. You can squeeze it out with your hand. It takes about an hour and a half, and you massage out all the inspissated meconium until you freed up, the bowel. And then, depending what the bowel looks like, you can either do a primary anastomosis if you were gentle and the bowel doesn't look bad. If you're in doubt, if you just don't like the way that things look, you've really beaten the hell out of the bowel, then do some sort of stoma. You can do a double-barrel ileostomy until the baby is stabilized, and then a few weeks later you can close the stoma. What's important to remember about meconium ileus is that it's in the ileum, and you got to contrast that. That's another board question. Is you may contrast that from meconium plug syndrome, which is a baby who has meconium stuck in the left colon, which is inspissated and stuck. Okay, once you flush it out, these babies are usually fine and don't have cystic fibrosis. We have one more. We have another few minutes, or we're running behind.
Yeah, Dr. Weinberg, you can maybe finish up. How many more slides do you have?
I think just one or two. These are important.
That's fine.
Okay.
Yep.
It's okay. It's okay, Jerry. Keep going.
Classic question they ask on the boards. Okay. What's important is non-bilious projectile vomiting. Guys, again, bilious, non-bilious, really, really important. Usually they're older kids, males. Bullshit. I've seen plenty of girls with pyloric stenosis, but it is more common in males. Hypochloremic metabolic alkalosis with paradoxical acid urine. You can look up in the books why that happens. Important thing is you don't operate these kids at 3 o'clock in the afternoon or 4 o'clock in the afternoon when you're tired, when anesthesia wants to go home. When do it when you're fresh, when the baby's in good shape, when you got your team. These are not surgical emergencies. Okay, you wait, you hydrate the baby. Standard treatment is half normal saline. Once the baby's urinating, I add potassium to the fluid, because what's going to happen is nobody's going to give potassium because they're afraid of his kidneys, and then you're going to retake the electrolytes at 6 o'clock the next morning just before you go to the operating room, and you're going to wind up hypokalemia, and then you're going to screw up a whole day because the baby's not going to be ready. So normal, half normal saline. Okay, once the baby urinates, add potassium to the IV fluids. Okay, operate when the chloride is up to 98. Okay, bicarb is less than 26. Chloride above 98 is important because okay, low chlorides are associated with respiratory failure in newborn. So wait until the chloride is up. Pyloromyotomy, okay, depending on how old you are and where you trained. Okay, most of us will do laparoscopic pyloromyotomies. Okay, the young whippersnappers have not seen an open pyloromyotomy. I can tell you that I grew up doing open pyloromyotomies. It's a nice little operation. It takes about 20 minutes. Okay, the scar is in the belly button. It is about the same size as laparoscopic scar. I think it's a fun operation. Okay, the babies will vomit post-op. Don't worry about it. Feed them. It's unusual to have incomplete myotomies unless you don't know what you're doing. Okay, this is what a picture looks like. Classic, big, elongated, thickened channel. Okay, once you've seen a sonogram of pyloric stenosis, you'll know what it looks like. Okay, it's unmistakable. Nobody, okay, rarely does a upper GI, and I don't remember the last time somebody felt an olive. Intussusception, okay, another cause of vomiting in children. These are usually older kids, toddlers. Okay, the ileum intussusception to the cecum. Okay, what's important to remember is the fifth line there. Really, really important. If you're waiting for current jelly stool, you're going to miss the diagnosis early on. Okay, if you got current jelly stools, without due respect to the policeman, a cop across the street can make the diagnosis. What you want to do is you want to diagnose intussusception early on, okay, and when the baby is just starting to have symptoms. Okay, and the three things I look for are a lethargic, listless baby who's having cramping abdominal pain, will often vomit. Okay, between episodes he looks like he's exhausted. Okay, you diagnose these things with a sonogram. Sonography for pyloric stenosis and for intussusception is 95% okay, successful, even in people who don't have the experience. Contrast enema is done only for therapeutic workup nowadays. You don't need to do a contrast enema to make the diagnosis. You can successfully treat them 80% of the time with a contrast enema. Okay, lead points such as Meckel's and polyps are more common in older kids. This may be a board question. You got an 8-year-old who's got intussusception. Okay, he's distended. What should you do? And I think the operation there is not to try to reduce it. The operation would be to go ahead and do a laparotomy or a laparoscopy if you're into it and resect the intussusception. They usually have a Meckel's or something more serious, such as a intestinal lymphoma. Okay, younger children, okay, you do a contrast reduction, air contrast reduction. If they recur, another board question, if they recur, you do it again. If they recur a second time, you do it again. A third time, you do it again. You save a laparotomy for the cases where you cannot reduce it. All right, guys. Sorry for the delay at the beginning.
There's just one question. If you from Mohammed, he asked if you violate the mucosa during a pyloromyotomy, what's the next step?
Traditionally, the board question is you close the hole, you flip the pylorus over, so now you do a myotomy on the posterior aspect of the pylorus.
Okay, perfect.
Okay.
All right. Thank you, Dr. Weinberg. We really appreciate it.
You're very welcome. Have a good day.
Thank you. Next up is Dr. Dwyer. He's coming back today for critical care. You want to take maybe a 2-minute break, and then we can start at 12:15, sir, if that's okay with you.
Yeah, that's fine.
Great. Awesome.